Good evening, delegates. Myself, Vinit Sonje, Group Product Manager for Diabetes Care Division of Lupin. Doctors, we at Lupin always strive hard to keep SCPs ahead in their knowledge updation. So with this principle at the core, we are here for a CME on very important topic. Doctors, as per India Survey 2023, India's diabetes population has already crossed 10 crores, which had grown by 44% in last 4 years. What makes this diabetes more serious are complications associated with it. So this calls for serious attention towards the management of diabetes and associated complications. Keeping this thought in mind, we have approached the most trusted body in the field of diabetes, that is ADA. ADA, as you are already aware, ADA has driven discovery and research to treat, manage, and prevent diabetes for last 82 years. So, with the official resources of ADA, we have come out with a comprehensive certification course on emerging treatment strategies for diabetes mellitus and associated complications. So today we are here for an inaugural CME with this certification course. So I'm very sure this CME will definitely add value to your day-to-day clinical practice in managing diabetes and associated complications. So all the delegates, doctors, without further delay, I hand over this session to Dr. Manisha Khalse, who is Deputy General Manager Medical Services at Lupin. So over to you, Dr. Manisha.
Yeah, thank you. Thank you so much, Vinit. So here I will take forward. Very good evening to all dignitaries and today's participant. This is Dr. Manisha. I'm working as a medical lead in the Medical Affairs Division of Lupin. On behalf of my organization, I extend a warm welcome to all of you in this scientific program and webinar topic named as Newer Strategies to Treat Diabetes Mellitus and End Organ Damage. It's my very great pleasure and privilege to introduce today's very distinguished speaker who doesn't need any introduction, but still I feel like it is my honor to introduce him, who has a significant contribution in the field of diabetes and cardiovascular diseases here. So we have Professor Antonio Cirillo. He is a research consultant in Italian Ministry of Health, IRCC, Multimedica, Milan, Italy. He is also chair of Diabetes and Cardiovascular Diseases Study Group, European Association for the Study of Diabetes. He is also professor. He is also published widely in the area of diabetes with over 500 original papers and several book chapters. Professor Cirillo has been consultant of the National Institute of Health, USA, for the program of research in 2003 to 5 related to cardiovascular diseases and type 1 diabetes. And he is member of writing committee of American Heart Association of the guidelines on acute hyperglycemia and acute coronary syndrome. He has also chaired the International Diabetes Federation Committee for the development in 2008 and in the 2011 for the update of guidelines for management of post-meal glucose. Currently, he is the chairman of Diabetes and Cardiovascular Diseases Study Group of European Associations for the Study of Diabetes, EASD. He has also served as a reviewer of 2012 European Guidelines in Cardiovascular Diseases Prevention in the Clinical Practice, as well as for the 2013 ESC Guidelines on Diabetes, Prediabetes and Cardiovascular Diseases developed in collaboration with the EASD. He has been member of board for the development of 2019 ESC Guidelines on the Diabetes, Prediabetes and Cardiovascular Diseases developed in collaboration again with EASD. Currently, he is also involved in the ESC 2020-22 program for the training of European cardiologists on the use of new anti-diabetic drugs. From 2009 to 12, he has been member of board of the IDF Europe and consultant of the EU Commission for the Framework Diabetes as a model of chronic care management, and he served as a referee of the European Commission for the 2017 grant program regarding diabetes of the Horizon 2020 program. He has served as associate editor of Diabetes Care from 2003 to 2011 and associate editor of Diabetes Medicine from 2005 to 2016. From July 2016, he has been appointed as an editor-in-chief of Diabetes Research and Clinical Practice, the official IDF journal. Currently, he is also in the editorial board of cardiovascular diabetology. Professor Cerillo is also winner in 1984 of the Italian Annual Award for Young Researcher, and he has been awarded with many distinguished awards also. In 2017, of Helmut Mehnert Award during IDF 2017 meeting. So you see, we are very privileged, sir, to be with you. So with this brief introduction of yours, I will hand over session to Professor Antonio. Over to you, sir.
Thank you very much for a very kind introduction. And it's really a great pleasure to be again involved in activities with colleagues from India. First of all, I apologize for the quality of my camera. I don't know what happened just yesterday. I tried to solve, but probably I just have to change my laptop. But anyhow, what is, in my opinion, relevant is that you can listen to me as well. You can see the slides in a good way. So I think that you do not miss so much if you do not see me so well. So I'm really proud to be involved in this specific program, aiming to interact, because you will see now how we get the opportunity in the next months to really interact on this program, focus on emerging treatment strategies for diabetes mellitus and associated complications. You see that this project is based on 5 different modules. One is diabetes and heart, the second is diabetes, kidney, and peripheral arteries. Then we have diabetes, microcirculation, the brain, diabetic foot, diabetic neuropathy. And there are some webinars dedicated to these topics, but I think what is really interesting is that you have 2 opportunities. One is to go personally and individually go through these different modules and to have, at the end, you will see a possibility of self-evaluate yourself, but also you have the opportunity to share with me some questions and I will try to do my best to answer in the right way to your questions in coming months. So I think that this is a very interactive way of how we can cooperate in this project. What are the aims of the program, specific aims of this program? This self-study program is intended to summarize the current evidence related to pathophysiology, diagnosis, and management of micro and microcirculation, microvascular complications patients with both type 1 and type 2 diabetes, emphasizing the principal recommendation in recent guidelines. As anticipated, there are 5 modules you see here to what each module is covering. And the learning objective of each modules are starting from diabetes and heart. You can have the opportunity after the completion of this module. You will should be confident with the assessment of cardiovascular risk factors, particularly smoking, blood cholesterol, high blood pressure, sedentary lifestyle, and obesity. You should be confident in the use of risk biomarkers in primary and secondary prevention. And finally, also very confident in diagnosis and management, particularly management of cardiovascular disease in patients with diabetes. The second module is focused on diabetes across kidney and peripheral arteries. And at the end of this module, you should be able to know the principal risk factor related to the development or progression of renal failure, the major risk factor associated with diabetes mellitus for the development of peripheral arterial thrombotic events. You remember, peripheral artery disease is not only a vascular problem, but also involves thrombosis very often. The guideline-directed therapies for prevention of both complications in patients with either type 1 and type 2 diabetes. The number 3 module is dedicated to microcirculation and brain. And the module is mainly focused in understanding the main manifestation of cerebral dysfunction in patients with long-standing diabetes. Also on principal clinical tests available to detect cognitive impairment. And finally, to the importance of good glycemic control for preventing microcirculatory complications in diabetes mellitus patients. The number 4 is focused on diabetic food. And in this case, we hope that you can learn a lot about the protocol for food care and follow-up in people with diabetes, about the main consequences of distal chronic diabetes ulcers, and finally, on the role of different specialists in caring and treating diabetic food complications. The last topic is neuropathy. You know, this is really a very complex and difficult to treat complication of diabetes. Let's say we have only few tools to face these very serious complications. And after the module, you should have the possibility to understand the principal mechanism leading to nerve dysfunction in diabetes, recognize and manage painful diabetic neuropathy, and apply the appropriate treatment in its different stage and clinical picture in patients with diabetes. So, as you see, these 5 modules are really trying to cover all the major problems, complications that can be present in a person with diabetes. Now, what I'm going to try to do with you is just to give you, let's say, a taste of what you can find in these modules, because I will try shortly. Of course, we do not have of course, if you want, you should go on each module to have a very comprehensive overview on all these, all the topics. What I will try in the next, let's say, half an hour is to engage you in some news related to each of these topics. So it's just to share with you something which is really updated in order that you can be, let's say, intrigued about the possibilities that you will have joining this project. I think that is a really unique opportunity. Let's start with the module 1, meaning diabetes and heart. What is new or almost new? I think that one of the most interesting news in the management of diabetes, and particularly in the management of heart failure in diabetes, which is a very common and frequent complications in people with diabetes, is a new consensus released by ADA at the end of last year. This consensus really is helpful because, let's be honest, as diabetologists or people who are caring people with diabetes, we were not paying so much attention to heart failure until a few years ago. But now we have new evidence, new tools, particularly new drugs for the management of heart failure in diabetes, and moreover, some very good markers which can help you not only in screening for the presence of a heart failure, but also to follow up what we are doing in terms of treatment. And this consensus is really relevant, helpful, because it gives some very practical advice. You see here that at the stage A, meaning only in people with diabetes considered a high risk, you should perform a screening. But what are you considering somebody with diabetes at high risk? You see here that when you have somebody with diabetes, one of the following comorbidity, meaning obesity, hypertension, hyperlipidemia, the kidney disease, cardiovascular disease, according also to the sex, people, males are more prone to heart failure. The recommendation of ADA is to screen at least every year, for the possible presence of heart failure. How you can do this? Today we have a very useful biomarkers, particularly the NT-proBNP, BNP, and the troponin, high-sensitive troponin. If you check these biomarkers, you can have an idea that somebody is or not at risk of already having even not very strong symptoms for heart failure, and then to consider to go more in details, to have a more deep evaluation of this person. You see here that probably if you look at the stage 1 and compared to stage B and stage C and D, the people working at the primary level or as the endocrinologists or diabetes specialists are mainly interested in stage A, because you see that the next situations are more close to the skills of a cardiologist. And my opinion is that if you screen and you think or you suspect that somebody is actually heart failure, this patient must be referenced to the cardiologist. But you see that the ADA consensus is considering a more comprehensive approach, which at the end of the day must be a multidisciplinary personalized care involving, you see, any kind of a specialist, but not only, in terms to also the family, also any person who can be very helpful. You see that there are several, I will not go in details. If you want, you can really download this consensus, which is freely available. There you see, according to different stages, there are very precise suggestions on who and which way should be engaged. So this is a very useful tool for practice, to go in practice to early screening of heart failure in diabetes. But what we have as a news in terms of particularly in cardiovascular disease and heart failure in diabetes, you see here that this very recent paper looking at the effect of empagliflozin on left ventricular diastolic function, in addition to usual care in people with type 2 diabetes mellitus, is showing something very interesting. By meaning that in this trial, it has been demonstrated a significant improvement of left ventricular diastolic function, which is something very common in type 2 diabetes, and not only, but is really very not so well recognized. So it's frequently and not well recognized. And it's very interesting that empagliflozin further the all good effect on any kind of let's say heart failure, different ejection fraction problem, also is very useful in this specific setting of left ventricular diastolic function. And this is very interesting because the effect is consistent across subgroups, including patients with congestive heart failure. So it's really, really an interesting outcome. Of course, the use of empagliflozin was accompanied by well-known effect on several risk factors like A1C, body mass index, uric acid, red blood cell count, and blood pressure. So this is already well known. And you see more in details related to what happens according to the different level of left ventricular dysfunction. Our empagliflozin was very successful in improving the situation. And then again, you see here that when you go for subgroups, it's very interesting to see that in any of these situations, meaning at any level of ejection fraction, or at any level of presence or not of heart failure, very high, meaning, the cutoff for NT-proBNP for the diagnosis of heart failure has been and been decided to show to be higher than 125 picogram milliliter. You see, so that in both these situations, empagliflozin was successful in presence of obesity, in presence of a high or not high A1C, in presence or not of a decreased GFR, and also in efficacious in this independently from level of uric acid. So good news for people with diabetes. But also we publish, this is why I'm sharing with you, this also very intriguing article, because we were evaluating the effect of SGLT2 inhibitors on the stent restenosis related events after acute myocardial infarction. You know that this is one of the issues. The stenosis of the stents, unfortunately, can hesitate in other cardiovascular events. And we were able to show a significant difference. You see here, these are the situation at the level of restenosis, that the presence of SGLT2 use was accompanied by a significant improvement of the possibility of to have a restenosis, which hesitated in a significant difference in heart outcome. You see here, when we were looking at the MACE, who was using an SGLT2 had less probability to have a major cardiovascular events, this is the clue, according to a reduced progression of restenosis in people treated with an SGLT2. And you see here more in details which kind of cardiovascular events contributed to the final results. And at the end of the day, all the cardiovascular events, meaning cardiovascular death, so the most important, all the three involved in the MACE were significantly improved by an use of an SGLT2. And another story is that what we can do in terms of heart failure treatment in patients with and without obesity. I thought, this is really also very, very important story, because in people without diabetes, but also only with obesity, very often you find the heart failure. And you see here, because this is looking at what are the doctors doing in people with obesity and heart failure. And you see here that is quite surprising that, okay, there is a good use of all the prescribed, suggested the drugs, recommended drugs in guidelines, particularly according to BMI. Higher is the BMI, more prone are the doctors to prescribe the treatment for heart failure. What is also interesting is that how many are receiving the therapy. You know that in the case of heart failure today, we are also speaking of 4 pillars. So this study was looking at to having at least 3 drugs on board. And you see here that according to some were also receiving nothing. While you see that the majority of the people with, let's say, 3 drugs on board were between the BMI 30 and 35, which is not the highest. So it's surprising that these people with the obesity, an appropriate approach for the management of heart failure seems to be not so really very well followed. You see here that if you look also at the different kind of compounds, there is some difference between the different groups. And again, not always the people with higher BMI are receiving, compared to the others, the right treatment. And in the multivariate analysis, according to just to see who was receiving the guidelines recommended therapy, for patients with obesity compared to patients without obesity, you see here that at the end of the day, people with obesity were treated less well. But we were able to show something even more intriguing. You know, that all the trials looking at the effect of just reducing body weight on cardiovascular events has been surprisingly negative, meaning that, of course, we are not questioning that weight reduction is very important for the prevention of cardiovascular disease. But at the same time, for example, if you think at the Look Ahead study, who was very successful in showing an improvement, not only of body weight, but also of many risk factors for cardiovascular disease. Anyhow, in this study, the primary outcome, meaning that the significant reduction of cardiovascular event, was not reached. So, and always this has been a very surprising situation. So why the weight reduction is not always accompanied by an improvement of cardiovascular profile? Briefly, in the last years, the possibility that more than the weight by itself, the weight variability, meaning is the change in weight in the time, can play a very significant role in determining the risk for cardiovascular events. There are many articles on this topic, but we were looking specifically using a huge database from the Swedish Diabetes Registry, which includes all the people living in Sweden. We were able to check, okay, but weight variability, we already demonstrated, also our group demonstrated that is dependent risk factor for almost any kind of cardiovascular complications. But compared to the variability of other risk factors, which also are risk factors for cardiovascular disease, what role is the weight variability playing? It's very important, it's less important than the others. And what we found out is that the weight variability is the most important risk factor for cardiovascular disease in diabetes. It's even more stronger than blood pressure variability, glycemic variability. You know, these also are very important risk factors for CVD in diabetes. And you see that this is sophisticated analysis. If you put together a huge weight variability with a very high systolic blood pressure variability, this is the worst situation. It is accompanied by the high risk to have cardiovascular events. So this is really an important news, because it means that it's not only important to reduce the weight, but even more important to keep stable the weight in time. Another story is the metabolic memory. You know, from DDC-CT and from UKPDS, it was coming out that if who was treated in the best way, intensive way from the beginning, had a reduction of any kind of complications, including cardiovascular complications. Surprisingly, when this trial was stopped and during the follow-up, all the people from the two arms were having almost in the follow-up the same A1C. Anyhow, the people having from the beginning a very good control still are showing a benefit in terms of reduction of complications, even after 30 years, for example, in the EPIC. And this has been just recently confirmed by a post-hoc analysis of KPDS. You see here, the evaluation was, what happens if you reduce within the first year from the diagnosis of 1% the A1C in terms of cardiovascular risk? And you see, you get the green line. What happens if you reduce 1% after 2 years? Then you get the blue line. What happens if you get 1% reduction after 3 years? You get the red line. This means that as soon you reduce A1C, you can improve glycemic control. This pays in long-term benefit in terms of reduction of particularly also cardiovascular complications. We were wondering what happens now when we have this new drug, because before in UK PDS they were not available. And we have used another very huge database from Italy, the MD Annals, which include almost 1 million of people, and we were able to check in terms of legacy of metabolic memory effect of glycemia. What happens if you introduce an SGLT2 after 1 year from the diagnosis, 2 years or 3 years, in people free of any complications at the entry in the study? We confirmed the presence of this legacy effect of glycemia, but the most important finding was that if you introduce an SGLT2 within 2 years from the diagnosis, you avoid the appearance of the metabolic memory, even in people who are showing high level of A1C, higher than 8%. So it seems that an early introduction of SGLT2 is very beneficial, not only for what we already know in terms of prevention, kidney disease, heart failure, and so on, but also because it is able to dramatically reduce the legacy effect of hyperglycemia. That is why in the paper we suggested that these findings should probably suggest that an early use of an SGLT2 inhibitor in the therapy of type 2 diabetes. And also we got this paper as post-hoc analysis, again coming from the Claire teaming, with the dapagliflozin, that this study, it was confirmed that dapagliflozin reduced the risk of first and total non-elective hospitalization for any cause in people with type 2 diabetes, regardless of the presence of atherosclerotic cardiovascular disease, including hospitalization not directly attributed to cardiac, kidney, or metabolic causes. So clearly, this is an indirect way to confirm what we already showed, that even in so-called primary prevention, the use of an SGLT2 inhibitor is very beneficial in terms of reducing the risk for future events. And finally, I think we see that what we told about NT-proBNP to be used as a biomarker is confirmed in this study, because in this study, NT-proBNP and troponin were associated with the MACE in patients with type 2 diabetes and high risk of atherosclerotic events, and individuals with high levels of both biomarkers, and dapagliflozin was associated with a reduced MACE events. So, meaning that NT-proBNP and troponin are good biomarkers to evaluate the effect on heart failure of a drug and follow up the treatment. And we had the confirmation that the SGLT2 reduced the MACE event. So again, good news. So this was something, just a few, honestly, few information compared to what you can get in the complete module. But what about the second module, diabetes, kidney, and peripheral arteries? I think that there is no doubt, unfortunately, even recently, it has been confirmed that the burden of a chronic kidney disease in patients with type 2 diabetes is high and associated with substantially increased rates of complications, particularly in those with comorbid heart failure. In the years, we got an improvement of all complications, but an absolute number of people with the kidney disease and diabetes is almost the same in the last years. So I probably also because I'm speaking about absolute number. So because we have a higher number of people with diabetes, this means that if the number is stable, and now we got an improvement, but the absolute number is still very high. So it's clear that kidney disease is a huge problem in type 2 diabetes. ADA has a specific recommendation for the management of kidney disease in people with diabetes. First of all, what about the screening? The IDA suggests that at least annually, urine albumin, spot urine albumin to creatinine ratio, and an estimated glomerular filtration rate should be assessed in people with type 2 diabetes with duration of higher more than 5 years, and in all people with type 2 diabetes, regardless of the treatment. Because you see, very often you make the diagnosis type 2 diabetes and people already had signal of kidney disease. In people with established kidney disease, urinary albumin and estimated glomerular filtration rate should be monitored 4 times per year, depending on the stage of the disease. It is very logical. If you have somebody in a normal situation, okay, you can check after 1 year. But unfortunately, because this disease could be rapidly progressive, if something is not good, maybe you have to check more often the situation. What to do as a treatment? Optimize glucose control. This is still a key strategy. Optimize blood pressure control and reduce blood pressure variability. So for the first time, the story of blood variability of risk factor is emerging as a target for the treatment in order to reduce the risk for or slow the progression of chronic kidney disease. Then you start with an ACE inhibitor or ARBs, and it's strongly recommended with this that we can start, but it's very strongly recommended when something is more serious, meaning when you have an urinary albumin, a creatinine ratio higher than 300 milligram creatinine. So, or an estimated glomerular filtration rate less than 60. So, never avoid the use of an ACE inhibitor or an ARB. Of course, periodically monitor creatinine and potassium. You have to be very careful about the risk of hyperkalemia when ACE inhibitors are used, or also diuretics. You know that ACE inhibitor and angiotensin receptor blocker is not recommended for the primary prevention of chronic disease in people with diabetes who have a normal blood pressure, normal urinary albumin to creatinine ratio, and normal estimated glomerular filtration rate. The level is very high. I think that this is a very important recommendation. Why? Because let's say many are tempted to use an ACE inhibitor or an ARB just to prevent even everything is going well. FDA recommend do not do this. Only if something is wrong, like high blood pressure or some signal of a kidney disease, then start an ACE inhibitor or an ARB. And if you see an increase of creatinine, do not stop an ACE inhibitor until there is no volume depletion. So it's well known that at the beginning, particularly at the beginning of treatment, you can have an increase of creatinine. Of course, today there is no doubt that the use of an SGLT2 is highly recommended in people with diabetes. Not only today, also not only in people with diabetes, but with the presence of kidney disease. Again, you see here, there are different levels, but anyhow, what is important is even at different level, I do not go more deeply because I think it will be boring. You can read by yourself this in the module. But the idea is that today, an SGLT2 is really a key strategy in the presence of kidney disease, even at the early or late stage. But also, you can consider the use of a non-steroidal mineral corticoid receptor agonist, because, you know, also this compound, particularly finerenone, has been confirmed to be very effective for the preserved kidney function in people with diabetes. And you see here that this substance is recommended. I have to announce something very interesting, that the trial with the finerenone also is started in type 1 diabetes. And I think it's a good news, because it's a paradox that in people with type 1 diabetes, there is nothing except good metabolic control or ACE inhibitors, what you want, but no one of these new drugs, meaning mineral corticoids, SGLT2, GLP-1, has been tested specifically for the prevention of these very serious comorbidities such as heart failure, kidney disease, or cardiovascular disease. And fine Renault is now tested in type 1 diabetes to see the effect on the kidney disease progression. Of course, in the people with non-dialysis dependent stage 3 with the or higher chronic kidney disease, the daily protein intake should be aimed to target level of 0.8 gram kilogram body weight per day. We know this is very important, the diet in people not only already in dialysis, but a very high end stage of kidney disease. And in this case, my ADA suggests to refer to a nephrologist because if the situation is serious, I think that a specialist is the right person to assess these people. And if you do not understand clearly what happens, so again, refer to a specialist to have help to understand better the situation, particularly in presence of a rapid progression of a kidney disease. And finally, this is a summary published at the end of last year of KDIGO. You know, this is a very important society which also cooperate with the ADA and other international scientific society. You see here this is a very interesting synopsis of a clinical practice guideline when you have the level of assessment, what to do in terms of patient selection, glycemia and volume. Again, what to do in terms of intervention, in terms of a follow-up. So this is something very comprehensive, very quick to read and to follow for practice in the daily activity. So you can have this, which has been very, very recently published in Annals International. And let's finish with some good news about fine Renault, which has been demonstrated is very efficacious compared to spironolactone, which is the other compound almost in the same class, with the people with treatment-resistant hypertension and moderate to advanced chronic kidney disease. You know, the conclusion is that finerenone was associated with a smaller reduction in systolic blood pressure and a lower risk of hyperkalemia compared with spironolactone without a potassium binding agent. So again, a good new drug for the management of kidney disease in people with diabetes and resistant blood pressure. Let's move to microcirculation and the brain. You know that dementia is one of the most serious, let's say, adverse events. That's the outcome of people with diabetes. But it looks very interesting that pioglitazone, which is not so much used anymore, at least in Europe, I have to say, is showing a very good effect in reducing the incidence of dementia in the new diagnosed people with the type 2 diabetes. So I think that it's interesting that we can consider again this drug for the specific management of dementia. And you see here that there is also an effect of the stiffness of artery stiffness related to A1C variability. You know, A1C variability, meaning glucose variability, has been strongly associated with the deficit of cognitive function in people with diabetes. And this gives another possible explanation, suggesting that the glucose variability in terms of A1C variability is accompanied by increased arterial stiffness. So there is a direct effect on the brain, which has demonstrated in other studies, but also an indirect, because this stiffness may mean that there is a reduction of blood flow in the brain. But what about specifically India? We got this paper showing that suggesting that the local type 2 diabetes population residing in Missouri, I hope that is the name pronounced, has high prevalence of cognitive impairment, evident from poor performance in almost all cognitive domains assessed by this test. Future studies could examine the general ability of cognitive function finding in diabetic patients across diverse geographic regions and ethnic groups, as well investigate interventions such as lifestyle modification and medication to prevent or delay the cognitive decline in those with diabetes. So at least we have evidence that also in India, honestly, I'm not surprising, the cognitive decline is a real problem in people with diabetes. And you see here, more specifically, which happened at the different of level, the different situation of the cognitive function in terms of attention score, language score, and so on. So I think that also is alarming that cognitive function is so much present in people with diabetes, because anyhow we are helping people with diabetes to live more. I think that we have to do our best to guarantee that they can live better. But in this other study published in 2000, end of last year in New England Journal of Medicine, the GREAT study, this study was aiming to evaluate the effect of different treatment, insulin glargine, glimepiride, liraglutide, and sitagliptin, on the possible difference among groups in the incidence of any cardiovascular disease. And the conclusion was that there is no different effect on several risk factors like dyslipidemia, hypertension, but also there was no difference in some complications like albuminuria, renal impairment, and peripheral neuropathy. I think, and also in terms of effect on different cardiovascular disease. I think anyhow there is a bias in this study, because it's not enough to compare the drugs, not looking at what happens in all the risk factors and all the effect altogether. Meaning, for example, we have data that it's important to reach the target of A1C, blood pressure, lipids, in the case to use also antithrombotic therapy. Well, but for example, we have evidence that at least in Europe, we have data that in many countries, A1C target is reached in only 50%. Blood pressure even less than 30. Lipids are more because they would use or not statin. The problem is how many are reaching the targets for all the three risk factors. We have data, at least in Italy, very recent, last year, that in only 5% of the people you reach the target, all the three risk factors. So probably it's a quite, even published in New England, I have to say, it seems to be a controversial and not so very deep approach in considering the difference, if possible differences about the different groups of people treated in different ways. But what about diabetic retinopathy? We have a specific recommendation from the ADA, and you see that the first goal is optimize glycemic control to reduce the risk or slow the progression of retinopathy, optimize blood pressure and serum lipid control to reduce the risk or slow the progression of diabetic retinopathy, and also, you need to screen as much as possible and very often, and you can do this in your setting. You can use retinal photography with the remote reading, a validated assessment tool. We also, in Italy, we make a photo, it goes to a centralized, where it's evaluated, coming back with the possible diagnosis. And of course, it's very important to have an exam before the pregnancy, because pregnancy is exposing people at very high risk for retinopathy. If you suspect macular edema or moderate or worse non-proliferative diabetic retinopathy, you need to refer to a specialist, to the ophthalmologist, which can use photocoagulation. Also, as it's very important today, we have antivascular endothelial growth factors, which can be sub-administered intravitreously and are very effective. So also this is very something which is very well known today, that we have the chance to stop the progression of retinopathy, but particularly of macular edema in people there. Let's say diabetic foot. I have only very short question. First of all, again, this is, as underlined by ADA, is still a very big problem. A lot of people are at high risk for diabetic foot problem, particularly for foot ulcers, and for this also to amputation. But I want to show something intriguing. In this paper, they were evaluating the effect of a gel made with amniotic fluid formulation of the dealing with diabetic foot ulcers, and it was successful. These are the photo, the pre-treatment and post-treatment. I think that we have to understand more many times. And finally, what about the diabetic neuropathy? There are some recommendations. First of all, screening for the, diabetic neuropathy is not so often screened and tested in people with diabetes. You need time, you need to apply some tests. But this is very important because the neuropathy is a very, very treatment, very, very hard complications. We have almost nothing. They're not optimized glucose control, because this is the key for the prevention of the neuropathy. So it's very important to find out, to screen for presence of a neuropathy in order to optimize, first of all, glycemic control. And there are some drugs you see here, which can help particularly to reduce the pain, which often is present in such a situation. And with this, I'm stopping. Thank you very much for the attention. And this is just a very short summary of what you can find in each of the different web topics. Thank you very much.
Thank you so much, sir. Thank you for taking us through this very elaborative and lucid presentation. Very nicely covered all the recommendations, and entire topic was so interesting. And so we have certain questions. We have received few other questions. If you allow me, I will pose those questions. Yeah, thank you, sir. So some of the questions which has come, that first question is about which therapy in long run is more beneficial in patients in preserving the pancreatic beta cell function and prevention of micro and microvascular complications. From perspective,
I think that there is no one drug for this. In my opinion, you need a combination. Because at least if you want to refer the evidence, because maybe other drugs also may have some protection, but this has been not demonstrated. For beta cell preservation, the class, I say the class, because of course, vildagliptin has been shown that this can preserve beta cells, is associated with metformin. I believe that probably it's a class effect, but anyhow, the only evidence is coming from a DPP4 inhibitor. In terms of long-term effect in preserving and protecting against macrovascular complications, okay, SGLT2 today probably is, you cannot escape to, we have published recently the story of metabolic memory, which is very important, suggesting that you can must use very early this class. Also GLP-1, probably they also are useful. So we have also this. But to avoid macrovascular disease, okay, we have the SGLT2 for kidney, which is considered a macrovascular disease. But if you look at retinopathy and neuropathy, then you need an optimal glycemic control. This is still the key. And any drug is welcome. I would to say, this is my personal opinion, that probably you need a combination of 2, even 3 drugs to cover all this spectrum, meaning vital cell preservation, cardiovascular kidney protection, good optimal glycemic control. So you cannot, in my opinion, but also this is coming out from guidelines. I'm sharing the IDF guidelines. We are also working on this aspect. You cannot reach all these targets with one drug. It's impossible.
Yes. Thank you so much, sir. Thank you completely. Taking the clue from your talk right now, the metabolic memory, if you see, because of suboptimal glycemic level, as far as even developing countries are concerned, like India, where you find many patients, almost like 80 to 90% patient present with suboptimal glycemia for a long duration, and that results in this metabolic kind of memory, and quite complications are very common. So, regarding the same, can we intercept early in type 2 diabetes to avoid these suboptimal glycemic levels from the perspective of cardiorenal metabolic continuum?
Yes. This is what we are. What we show is very interesting. I think the data are very strong.
Yeah.
Okay, now we publish Lancet, so I think that the journal is credibility. What we were able to show is that it's very important that when somebody is at a diagnosis and not having, because if he has already complication, there is no doubt you must use an SGLT2 to prevent a further progression of complication. But what is important is if there is no complication. In this case, the window is very short. We were able to show that within 2 years, if you are at 30 years, does not work anymore because the lag time is too much. So my suggestion today should be start immediately with, let's say, a combination, including an SGLT2 inhibitor.
Right, sir. Right, sir. And sir, Professor, one more question regarding the same. That what are the consideration in terms of patient factors you think about while initiating these therapies? So what factors we need to consider to initiate? Because if you see, there is spectrum of conventional anti-diabetic drugs are also available. How to choose? What approach we should adopt in getting into managing the patients?
I think that honestly, you can be driven by some stuff, but there is some conclusion if you follow different guidelines. For example, in the ADA ASD algorithm, but also in European Society of Cardiology guidelines, you find the recommendation to start with an SGLT2 or GLP-1 independently from the level of A1C if there is a risk of cardiovascular or kidney disease, meaning that you have to use in anybody if he's at risk. Now we show, but also there is another paper indirectly. I will not show, able to show that when you associate an SGLT2, you can prevent better the cardiovascular complication compared to other drugs. But usually you need also very good control. So what I mean, I suggest that in any patient who can take, because also in India you are lucky in terms that now, for example, SGLT2 are not very expensive. I know this. In Europe, they are still very expensive because they are still under the patent. But this in India, I know that some companies, many companies are producing an SGLT2, generic SGLT2, which is cheaper compared, and it's affordable. I don't know if it's affordable by everybody, but for sure, the majority of the people can afford this. Yeah. And I believe that you must take on board now an SGLT2 with at least one other drug, because one drug, again, is not enough. Let me summarize. In blood pressure control, we know that about hypertension, there are 2-3 pathways engaged. And we usually start immediately with the combination. No, lower the dose, but combination. in diabetes, we have at least 8 pathways, the octet of the front. Do you think that one drug could be enough? So I don't think so, honestly. So if you want to take more, you need 2, 3 drugs. And as you know, that also Professor De Fronzo is on the same way.
Yeah. Another point here, we have actually one more question, very interesting question. The gliflozins carry the increased risk of certain cancers, like bladder cancer and all. These were very earlier, this was the thought process, but still it is there in the minds of many of the physicians who are writing and prescribing the drug. So can you elaborate, what is your thoughts on the same, sir?
Or which drug, dapagliflozin?
Dapagliflozin?
But
Yes.
in the bladder cancer.
Bladder
I
cancer,
think
yeah.
this is completely over, because, any survey from FDA and also from EMA was was relaxing that this is not, and particularly because unfortunately the data are coming from people with diabetes. We are waiting for the marketing protection, marketing surveillance in people without diabetes. Because in people with diabetes, this kind of cancer is very frequent. So the problem is that you cannot understand what is related just to diabetes or what could be related to the drug. But honestly, this story of drugs and the cancer is something. I was living the story of a glargine and the cancer, and this was fake. I was living the story of a pio and cancer, and also this was fake. So, honestly, I think that anyhow, if there is the risk, but I think it's not any more demonstrated, when you put in the balance the advantage with the risk, I think that at least you just can survive very often a check to see if everything goes well or not. But what is demonstrated today for an SGLT2 is so important. I think that it cannot be avoided to use.
Okay. So there are how we can go ahead means is it fine about the question and answer? I'm asking the organizer. So is there any question from your end, Vineet and other people?
Fine, Dr. Manisha. If there are a few more questions you could have shortlisted, we can take a quick consent from Dr. Antonio and we can take those questions. Otherwise, we can just close it.
Yes. So I feel there is a time constraint also. So Professor Antonio, thank you so much for your elaborative session. So I will wrap up this session by giving a small note of gratitude. So thank you for your enlightening and lucid talk, explaining various modules in the programs as well, and the importance of emerging treatment and challenges routinely faced by the clinicians for early detection of complications in type 2 diabetes. So Sumit, would you like to add up here, or how it is?
No, I guess that was quite comprehensive and brief version what Professor has taken us through. And I'm sure, Doctor, all the audience who have heard you have certainly enjoyed the scientific discussion and the latest update, particularly the references, whatever you have used are the latest, and you have also covered the entire paradigm in and around of diabetes and comorbid condition. So certainly this would encourage everyone to go through the entire program of this emerging strategy is in T2DM under the banner of ADA and under your guidance. So that was quite comprehensive. I once again, on behalf of Lupin, which always we try to establish a good scientific connect through best of the authorities in the globe, and will continue to do so. So on behalf of Lupin, I once again thank Dr. Antonio as well as Dr. Manisha, Chaya, Vinith, and team. And thank you everyone for joining us here.
Yeah, thank you viewers also for today's participation. Thank you. Thank you, Professor Antonio. Thank you.